Nā mai haere mai, kia ora koutou, hi manataki ahau ki te huinga hapai tangata, ko Barry Milne ahau. So hi everyone, I'm Barry Milne, I'm the Director of the Compass Research Centre, and welcome to the Compass Student Presentations for 2026. Tori is a PhD student in statistics. She's supervised by Matt Edwards. She's looking at novel methods for making Māori data relevant to local decision making. And today you're going to present on rheumatic fever stuff. Okay.
Kia ora koutou. Hopefully you can see me. Ko te rai o rahiri te maunga, ko ngahia te awa, ko ngā te toki te hapu, ko te rai o rahiri te marae, ko Tori Diamond tōku ingoa. Kia ora everyone, my name is Tori, and I'm going to be presenting on statistical approaches for making Māori health data relevant to local decision making. And I'll be specifically focusing on a portion of my PhD research, which uses rheumatic fever. So I am a PhD student in the Department of Statistics, and I'm supervised by a few people. I think about 5 people. So yeah. I mean, majority of them aren't here; they're overseas. So I've got Barry, which is great. So yeah, but yeah, quite a big team, and it's a fairly big project. But I'm in my second year now, so I passed my confirmation review in September last year. So a few of the things I'm presenting on kind of will be towards the beginning of this portion of the case study, because I have been looking at COVID-19 vaccinations as well. So this is an overview of the presentation. I'll first go over the research question and then basically kind of an overview of rheumatic fever in New Zealand as well, along with the objective, data sources, methods, and then some results, and moving on to next steps. So I'm sure everyone's familiar with this, the disclaimer, which I have to show based on a few of my results that I'm going to be presenting as well. So the research question for the majority of my project is: how can health events with contrasting count sizes due to rare events in small regions be approached using Bayesian methods? And so Bayesian statistics offers strengths in the way of incorporating prior information and also prior beliefs into our models. So this contrasts with frequentist approaches, which can be quite limiting in a lot of ways, mainly based on p-values, whereas Bayesian models can have hierarchical layers and actually add more complexities as well. So it's actually really important for the New Zealand context because we already have existing beliefs and prior information about especially Māori populations and how they navigate health systems, how they're actually impacted in the health system itself. And so the aim is to investigate impacts of survey and administrative data determinants for 2 health outcomes for the Māori population. And so while I've just said how great Bayesian stats is, I won't actually be presenting any of that stuff today because I'm in the process of building those models. So this is kind of an introduction into the kind of path that I'm taking, and this information that I will be presenting will be informing those Bayesian models that I'm creating at the moment. The case studies, like I mentioned, using the IDI, but I'm using 2 complementary case studies. So the first is rheumatic fever. Rheumatic fever is typically a rare event, but it's an inflammatory illness that can occur with untreated cases of strep throat, and often with multiple untreated cases of strep throat as well. So it typically affects children, and it disproportionately impacts Māori children and also Pacifica children as well. So although annual rates of rheumatic fever have actually declined across time due to modern healthcare, it's actually still very prevalent in New Zealand today, which is really concerning. So the other case study that I will be looking at is COVID vaccinations. And the reason I'm doing that is because it's a more common outcome, but at the same time, it has large spatial variation. So access to vaccination services throughout New Zealand where actually, there was a stark difference depending on where you were in the country. So by breaking down by region, you'll eventually have smaller counts of people within that region, hence the denominator being smaller. So I'm kind of applying these Bayesian models to two different contexts, one being rare event and one being small regions. So that's the goal with the project. And so I'm focusing on rheumatic fever today. And so in the statistical context, basically previous research, there are well-documented relationships between rheumatic fever and household factors, and also things like, crowding, deprivation, and also healthcare access as well. So there is a greater risk for Māori and Pacific, tamariki and rangatahi, so teenagers, young adults, basically aged 4 to 19. And then things like modifiable risk factors, housing risk factors, so household crowding and barriers to primary healthcare as well. However, there has been a clear priority outlined by government to actually minimise rheumatic fever within the community. One of these things was outlined in the Rheumatic Fever Roadmap, which is from 2025 to 2028, but also the Healthier Homes Initiative, which was actually, at the time, I think it was in 2013, built off of the back of preventing rheumatic fever within the community. And so that's obviously played a part in improving household factors in New Zealand, but kind of wanted to see how well it's done as well. So to give you an idea of incidence rates of rheumatic fever across time, there are persistent ethnic disparities. Basically, the blue line is Pacific, red line Māori, and then the green line are national rates. And I've just done these three subgroups because it gives you an idea of those disparities across time as well. And so we can see that Pacifica definitely have the highest rates of rheumatic fever across time, but also Māori, there is a difference between national rates as well. So to give you an idea of counts by 10-year age bands, this is for all available public hospital discharge records from the time that I basically got them out of the IDI. So the highest rates were seen in 10 to 19-year-olds, and then 0 to 9-year-olds, and then 20 to 29. And the gaps in that time series are due to suppressed counts, which are lower than 6. Given what we know about rheumatic fever in Aotearoa, it affects subpopulations disproportionately to this day and could be a result of household factors such as crowding, mold, and maybe dampness, especially with the Healthier Homes Initiative coming in 2013. So what I wanted to look at was potential exposures of interest. So these were collected from the 2023 census. I wanted recent measures. In 2018 did have a few issues as well. But at the same time, from what I know, I think there's around 10% of household and dwelling forms that were missing from my knowledge. So it doesn't really help this. But it's also the best that we have because these aren't actually measured within administrative data outside of the census. So that's the best I could do at this stage. So looking at rheumatic fever cases after that period of collection, so 2023 census, after March 2023, using public hospital discharge records. This is an outline of all of the data sources that I'm using from the IDI. So firstly, census 2023, individual. I've also got region aspects in there as well. I might come back to that later on once I've done the COVID model and potentially look at regional differences as well. Then I've got publicly funded hospital discharge records for rheumatic fever. And then I'm looking at ethnic differences as well, potentially PHO enrollment for that access to healthcare. And then censoring purposes, looking at overseas spell and death records as well. So across the past few weeks, I've been creating a kind of a case control or nested case control study. So to define the cohort, they have to be usually resident population, not have died or immigrated permanently before March 2023, and also have no prior rheumatic fever or rheumatic heart disease diagnosis. So rheumatic heart disease can occur later on in life if someone has had rheumatic fever earlier on. So this was the eligibility for the cohort. And then case definition, a case had to have had rheumatic fever within the period of March 2023, so after the census night, until March 2025. And the reason for March 2025 was because I'm using the October 2025 refresh. So that was the latest availability. So that's actually the end of the study period. So everything's been matched on that date as well. So for controls, they can't have had rheumatic fever or rheumatic heart disease at the time of matching to a case, but they can have rheumatic fever after that date. They then become a case, and then they exit the risk set as well. And so for every one case, there were 5 controls matched. And so this was a suggestion from one of my supervisors as well, to match 1 to 5. And they were matched on birth month, birth year, ethnicity, and then also the index date as well. So for these results that I'm about to show you, I used, within R, I used the Match It package. That was one of the packages I used. But then I also did it manually to kind of validate what I was seeing and made sure that it actually made sense. And so within that, you then have to use the survival package and use CLogit to get conditional logistic regression output. Basically, this is a very, this is kind of the first steps of looking at these results. So firstly, I looked at crowding. Crowding showed that there was, compared to those in uncrowded or non-crowded households, those in crowded housing did have a higher risk of rheumatic fever. When I used mold only, those with mold greater than an A4 size sheet of paper always did have a greater risk of rheumatic fever compared to that reference of no mold. Same with dampness as well. When I put everything into the model, also these 3 variables, we could see that there wasn't huge impact on the coefficients when including crowding, but it was likely that there's correlations between crowding and these other 2, obviously, so that made sense. But yeah, so it's possible that like the effect of dampness and mold is due to crowding. When you think about it, if a household has more people within it, there's potential for confined spaces, therefore more water vapor, therefore higher risk of having dampness and molding as well. And so the next variable that I did want to look at was renting. So this was found to have an impact or higher risk of having a rheumatic fever compared to those with not in rented households. And so I would have expected maybe the crowding features would be like a mechanism for renting as well. But when you look at renting and when you consider when the Healthier Homes Act came into play, it's likely that rented households may have better housing conditions now compared to possibly 10 years ago as well, which is a good thing. And so it's, yeah, basically housing features may have improved over time, which is why we're seeing this change. But also, I think there is a lot of multicollinearity as well, which is playing a part. So the next step is to look at the correlations between these before I go any further, which I'm doing at the moment. And so they will inform the model, which will be created for the Bayesian analysis portion as well. So when you're considering rheumatic fever diagnoses, there are a few caveats. And one of the main things is that there could be potential undercounting, but also that when you're trying to look at that causal pathway, you would like exposure to strep throat to be measured as well. But obviously this is mainly considered at the GP level, which we don't have access to. And so it's a little bit hard to look at it from like a prevention point of view as well. The other way you could look at it is through pharmaceutical dispensing, but at the same time, it's a very general medication that's given. So it's really hard to actually narrow down who has had a rheumatic fever, who hasn't. And then computational limitations within the IDI. So this is to do with those Bayesian models and actually creating those. I have run into a few issues with that so far. But yeah, so like I mentioned, correlations between those household factors are next. And then running Hamiltonian Monte Carlo or STAN models, Bayesian models within the IDI. And then also considering the vaccination case study, which will specifically look at regional effects. And I will be using hierarchical models using NLA, which is another Bayesian approach as well. And yeah, that's me. Thank you.
For the different household conditions, I'm wondering if there's, rather than looking at patients, if there's a case for looking at some combinations of those factors and how that influences risk. So if you have a crowded house and it's mouldy, is that different than if you have a crowded house that isn't mouldy? Or maybe there's a case for some sort of cumulative?
I was kind of going for a similar-ish, but actually more of like testing a structural equation model or like a mediation type model where it's like, is the association actually explained? So, you know, between crowding and risk kind of explained by the reason, so increased likelihood of having mold
attendance. Yeah.
That's actually the same thing, but different
ways of testing.
But I just think because they are so related, but they might also be like differentially interacting with each other. And it might be that if you have crowding and mold, it's a really big issue. If you just have one or the other, not so bad. And it might be, it'd be so interesting to see. Sorry,
no, you're fine.
I'm just amazed that no one's done this before.
Yeah, I know.
Right.
It's
right. Risk factors for rheumatic fever. I mean, and we've got there is good data out there.
Yeah, there's been a few community intervention studies and upping the presence of actual testing. But when you test more, you find more as well. So then the rates increase. So it's kind of a catch-22. But from my knowledge, like I haven't seen too many IDI studies actually looking at rheumatic fever. And I don't know if it's because of the small counts aspect of it as well, but when it's and when it's disproportionately impacting subpopulations, that's when it's even more important. And I think the other thing with renting was that we were thinking about, okay, if you're in a rented household, are you more likely to actually report that your household has mold and potential dampness because you're in a rented household as well? Does that play a part? So it's
probably the numbers just get really too small. And I was just wondering if there are other surveys that include questions that they're probably like, I don't know, GSS, but the numbers are probably so small.
I think the survey is the only one that includes those questions on mold, but specific work done by the groups at University of Otago, Wellington, likes the healthy housing people, but also Michael Baker and Amanda Kowalczyk. They may have done specific studies as well. I'd look there.
Because I think Jason Gurney and Michael Baker have done quite a few community prevention programs as well, and looking at the Healthier Homes Initiative and how that's actually made an impact in rheumatic fever cases.
Thank you so much. Just to congratulate Tori, it was amazing. I've never seen anything like this before. And I love that you're using Bayesian stats because I think this is the future and that you are doing research on using that method. So cool. I'm just
Thank you.
wondering about the non-significant results, or where the like the significance, the range was so wide in some of the tables, right? So I'm just wondering whether that was because it was actually there was no significant, like in damp or mold, or it was because maybe the model didn't identify that was actually stronger association. So what do you think about that, or whether you could, I would like to know your opinions on that. Thank you so much.
Yeah, I think potentially one of the reasons for that wide range with those confidence intervals would maybe be to do with the cases, the amount of cases that I have as well. There were only 339, I think, and potentially missing values as well. So there is quite a few people missing from that household and dwelling portion of the surveys, and causing another problem as well. So there's a lot of different factors to it, but because of using conditional logistic regression, I think I was very aware that it was likely to come up with these types of results. But I'm hoping that once I use the Bayesian models, because I have some background knowledge in this area and also from these results that have shown, these will kind of indicate and strengthen those Bayesian models, because Bayesian models are typically better with small counts as well.
Tori, I really enjoyed listening to you. I feel like you're in a lot more developed phase of your PhD than I am, and I was actually taking notes, and I might reach out to you to ask a couple of questions. I wanted to have a comment on the regional variations and climate that someone else I couldn't see mentioned before me. I was interacting with PHF Science not too long ago. That's what ESR became. And they're running a study on how increased humidity and temperature is infecting diseases, especially children, chronic disease. I put a link to that. You might be able to reach out to them. I know Barry has connections. So, they might be able to either use your results for their modeling and reference your work, or you might find something interesting in what they have found.
Yeah, that sounds really interesting. I actually, firstly, I was keeping mental notes of some of the things that you were presenting on, because I saw that you were kind of informed by a lot of the Bayesian approaches as well, which was great to see that I'm not alone. But yeah, that's really helpful. I haven't heard about this and what you've mentioned with ESR, so that's
quite new, I think.
And it builds a bit on what Mariana was talking about, or more the kind of connections between your talk. When you showed that graph at the start about the rheumatic fever rates over time, and the Pacific rates is high, but it's bouncing around because of low numbers, I guess.
Yeah.
But there seemed to be a bit of a dip in 21 and 22, and I just wondered if there was some protective lockdown effect. You didn't really see the national population, but the Pacific population also is in Auckland.
Yes, exactly.
I don't know what the number is, 2/3 are they in Auckland, something like that.
Yeah.
So I don't know, it might be too difficult to detect, but it's building on what Mariana's doing.
Yeah, definitely.
Yeah,
that's a valid point for sure. I think it's worth looking into.
One. The other one that you might want to talk to Mariana about is the processing issues in the IDI with Bayesian statistics.
Yeah.
Because I think it's a general problem. I don't know if anyone's solving it, Mariana, but it would be interesting. You guys should get together basically and just talk.
Yeah.
Yeah. That sounds wonderful.